Imagine this scenario. And to be honest, it's not just an exam question, is it? It's a chilling reality for pretty much every junior doctor.
Absolutely.
You're the only junior doctor covering 2 wards. It's 17.45, that horrible twilight handover time, and your bleep is already screaming. And the list of things hitting you all at once is, well, it's overwhelming. You've got a new patient with acute chest pain, and their ECG is showing dynamic ST changes.
So an MI protocol immediately.
Immediately. Then you've got a suspected sepsis patient, and UWS2 score just spiked to 8, and you're already pushing that golden hour for IV antibiotics.
Right.
At the same time, the lab rings with a critical potassium, a K+ of 6.4.
Yeah.
A true physiological threat.
A cardiac time bomb, basically.
Exactly. And just to top it all off, 3 sets of TTOs, the discharge meds are waiting, blocking beds that were needed hours ago. The nurse in charge looks worried, and your phone is ringing.
Yeah.
It's your registrar.
Of course it is.
So what do you do first? More importantly, how do you navigate the next half an hour without something going catastrophically wrong?
And that single moment, that decision-making process, is the absolute heart of every critical shift. And, it's the highest yield topic for the MSRA SJT.
Welcome to the deep dive. Our mission today is, I think, really clear. We want to hand you the core truth for these clinical workload scenarios.
The foundational logic.
Yes. The one-sentence takeaway should be this. For clinical workload scenarios, patient acuity and time-critical risk always beat arrival order or convenience. And safety has to be created through structured planning, early escalation, and really robust documentation.
It's not about running faster, it's about thinking smarter.
Exactly. So we've taken SJT textbooks, the latest GMC Good Medical Practice guidelines from 2024, and practical NHS frameworks like SBR and New WS2 to distill this down.
The goal is to give you those simple, repeatable mnemonics and memory hooks, the action plan you need when you're under fire.
This is your guide to safe clinical governance when everything is hitting the fan.
And it's so important. If you're listening to this and you're tired or stressed, just remember, the pressure in that scenario is exactly what the exam is testing. If you miss the logic here, you risk patient harm. We're here to give you that blueprint for acting safely.
Okay, so let's start with that tension between what feels right on the ward and what the exam is actually looking for. The clinical reality versus the exam logic.
Yes, this is a huge point. In reality, you might be tempted to just multitask, run faster, try to do it all yourself.
The hero complex.
The hero complex, exactly. But the exam is testing your ability to ensure safe governance. This topic comes up so often because poor prioritization doing the TTOs before the K+ 6.4 leads directly to avoidable harm.
So the exam isn't rewarding martyrdom.
Not at all. It's rewarding safe triage and your ability to coordinate a response, not your ability to struggle alone.
That's a really crucial distinction. It's the difference between being the hero who burns out and misses a critical result versus the safe doctor who coordinates and delegates. So where does the GMC actually define this duty?
Well, it anchors directly into Good Medical Practice 2024. The first big one is under Good Clinical Care. Paragraphs 6 and 7 say you have to prioritize patient safety and, critically, you must work within your limits.
Okay, that phrase, working within your limits, I think that can be misunderstood. In that crisis moment, chest pain, sepsis, high potassium, how does a doctor even know their limit has been reached?
That is the core insight the exam is looking for. Your limit isn't just about feeling tired. It's reached the moment the number of time-critical tasks exceeds your capacity to do them safely and simultaneously.
So with those 3 patients, you're already past it.
Instantly, you cannot safely single task all 3. So your professional duty immediately pivots from doing the tasks to triggering the safety mechanism.
Which is escalation.
Which is urgent prioritization and immediate. It's about effective resource use in paragraphs 14 and 15. This means 2 things. 1, you can't waste time on low-value tasks. You can't spend 40 minutes chasing a routine X-ray when a patient's potassium is sky high.
Right.
And 2, it means coordinating early. Sustainable practice means getting pharmacy or the site team involved proactively to prevent bed block, not waiting for the crisis to hit.
And that's the TTO scenario, isn't it? Leaving discharge prescriptions until the end of the day is a resource flow issue.
Precisely. It's a failure of resource stewardship. It creates a bottleneck that puts patients in A&E at risk because there are no beds for them. It's all connected.
And the third anchor point must be about sharing the load, right? Because you can't do it all alone.
Exactly. It's the duty of safe delegation and continuity covered in paragraphs 66 to 68. The GMC is crystal clear. any task you delegate must be within the competence of the person you give it to, and you have to supervise them appropriately.
And this is what kills those classic SJT trap answers.
Instantly. Things like, hand the critical blood results to the medical student.
Yeah, you see that one all the time.
All the time. But a student is not competent to hold that responsibility. They're not clinical cover. And then there's continuity of care, which requires clear contemporaneous records. That's paragraphs 69 to 75.
So documentation isn't just paperwork.
It's a critical safety net. If you delegate a task and don't document the handover, the next person can't continue the care safely. It leads directly to errors of omission.
Okay, so let's just nail down those common traps the SJT is designed to punish. Knowing what not to do is just as important.
Definitely. So the exam will penalize you for 1, abandoning the ward, leaving for a meeting without arranging competent briefed cover. 2, silent struggle, ignoring escalation and trying to manage alone until it's too late. 3, lacking documentation, no handover, no plan. 4, unsafe delegation, using students or untrained staff.
The classic ones.
And the big one, 5, ignoring the sickest patient to clear admin jobs first. All of them are a fundamental breach of that core safety mandate.
So we know the GMC rules. Now let's build the action plan. When that tidal wave of jobs hits, you need a framework. What's the single non-negotiable principle?
The non-negotiable principle is that clinical acuity takes absolute priority over everything else. I mean, everything.
It doesn't matter who asked first.
It doesn't matter who asked first. It doesn't matter if you promised a consultant a note. A deteriorating patient or one with an immediate physiological threat comes before any routine task, meeting, or admin. It's the sickest-first rule with 0 exceptions.
Okay, but let's go back to our opener. The chest pain, the sepsis, the K plus of 6.4, they all sound incredibly life-threatening. How do you actually triage that level of acuity?
Right, and that's the next level of thinking. You have to rely on established frameworks. First, you filter through the ABCDE assessment. Airway, breathing, circulation, that's your primary triage.
Standard practice.
Then you overlay NUWS2 triggers, which are designed specifically to flag deterioration that needs a senior review right now.
And then, if they're all still screamingly urgent,
then you use time-critical windows to break the tie. The K plus 6.4 is an electrical time bomb. It needs immediate membrane stabilization. Sepsis needs antibiotics within 60 minutes. Dynamic chest pain needs immediate assessment and referral.
so they're all now jobs.
They are, but the K plus of 6.4 is probably the fastest route to a cardiac arrest. So your mental model should be immediate physiological threat first, so the potassium, then the other deteriorating patients, sepsis and chest pain. But the key is you address all 3 simultaneously by escalating and assigning roles. No single junior can do all 3 safely.
Which leads perfectly to escalation. I think so many junior doctors see calling the registrar as, I don't know, admitting failure.
And that's a mindset we have to break. Escalation is not failure. It is creating capacity when demand exceeds the safety limit.
I like that framing, creating capacity.
That's all it is. When you have 3 life threats at once, you are outside your safe capacity. The safest, highest-scoring doctor recognizes this and escalates early to their registrar, consultant, or the site team. It divides the workload and brings in senior oversight instantly.
So the SJT logic is, recognizing the unsafe workload is step 1. And the highest scoring action is the one that triggers a system safety response.
Precisely. Silent struggle is a low-scoring option. Raising the alarm is high-scoring because it minimizes how long the patient is at risk.
And finally, let's just loop back to documentation, because it's the thread that holds all of this together when you delegate or escalate.
It is. It's the mechanism that protects the patient and the system. In these scenarios, documentation means recording the cover plan, who you delegated the sepsis review to. It means noting the escalation thresholds you agreed. Call the registrar if the chest pain comes back.
It's more than just the clinical notes.
So much more. It's taking a snapshot of the now, next, later board so there's a public record of priorities. And most critically, it's the explicit handover details at the end of your shift. Without that, continuity of care is broken. It's the final, crucial step of closing the loop.
Okay, time for the practical tools. We need some structured action plans for this. We've got 3 mnemonics to help. Let's start with that long, messy list of clinical jobs. How do we bring order to that chaos?
Right, so for that we use the PRUDE framework.
The PRUDE framework, okay. But isn't sickest-first enough on its own?
Well, sickest-first is the compass, but PRUDE is the map. It forces you through the steps to turn that decision, like the K plus 6.4 is the sickest, into a safe, documented action that involves the whole team. It stops you from just getting tunnel vision on one patient and letting the rest of the ward slide.
Okay, let's break it down. P, What does that stand for?
P is for prioritize high risk. That means acuity and time sensitivity. You're looking for immediate threats. Hypertension, high new WS2, critical blood results like our K plus 6.4, or dynamic changes on an ECG.
And if you have two high-risk patients,
The SJT will want you to choose the action with the highest risk reduction per unit of time. So, for instance, giving IV calcium gluconate for hyperkalaemia has a massive immediate impact on preventing cardiac arrest. That might even pip starting sepsis treatment, which has that 60-minute window. You tackle the fastest route to death first.
got it. Okay, next is R.
R is, for record, a visible now, next, later plan. And the key word there is visible. This isn't just for you, it's for the nurse in charge, the covering doctor, everyone. A task that isn't on the board is an invisible risk.
So if you get pulled away to the cardiac arrest call, everyone else knows the sepsis antibiotics are next up.
Exactly. It prevents tasks from getting lost or duplicated. Both are major SJT flaws.
Yeah, do you?
U is for urgently escalate capacity issues. This is crucial. If your now list has more than one life threat, you must escalate. And this isn't just a quick update call. This is telling your registrar or the site manager, I have 3 simultaneous life-threatening situations. I cannot manage this safely. I need senior help on the ward now. You're escalating the risk to the entire system.
Right. And that leads to D for delegation. It seems to be where a lot of people trip up.
It is, because it's nuanced. D is for delegate safely, and that means using a tool like SBR and checking competence. You delegate tasks, not responsibility. You might ask an experienced F2 to review a stable patient and give you an SBR, but you can't delegate the decision to discharge an unstable one.
So you have to be really specific.
Very. Using SBR is key. State the situation: patient is hypotensive, background admitted with pneumonia, assessment, I think they're in septic shock, and a clear recommendation: please review and prescribe more fluids. It ensures the risk is transferred safely.
And finally, E.
E is for enter note Shand over clearly. This closes the loop. Document your prioritization decision, who you delegated to, and any deadlines. If you had to cancel something non-clinical, write it down. Teaching canceled due to critical clinical surge. It's your auditable trail. It protects you.
So PRUDE is a complete risk management cycle. Prioritize, record, urgently escalate, delegate, and enter notes. Okay, so PRUDE is for planning the list. What about when you get that sudden surge, that cascade of interruptions?
For that, we use the PASAR framework. This is more about human factors. It's designed to minimize high-risk errors when you feel rushed and your brain is under huge cognitive load.
The SJT rewards the calm doctor, not the frantic one.
Always. Which brings us to P.
Let me guess. Pause.
P for pause plan. A 30 to 60-second micro-huddle. When the bleep goes, the phone rings, and a critical result lands, your instinct is to just react. Don't. Stop. List the inputs, assign a priority. That 30 seconds of pausing prevents minutes of chaos and stops you from rushing a high-risk step like a drug calculation.
Not pausing is a classic trap.
A guaranteed low score because it leads to bad decisions.
Okay, A.
A is for assign tasks with owners and times. Who is doing what and by when. If you escalate to the registrar, you assign them ownership of the chest pain review with a time frame. Please review within 10 minutes. Without an owner and a deadline, tasks just float away.
Another omission trap. And C.
C is for clock and single task critical steps. Use timers for things like the sepsis 60-minute window, but the most critical part is single tasking.
What do you mean by that?
If you are prescribing a high-risk drug like insulin, consenting a patient, or doing a procedure, you must protect that time. No interruptions.
And what if you are interrupted? Say a bleep goes off while you're writing an insulin prescription.
The safe, high-scoring, GMC-approved action is to stop what you're doing, secure the drug chart, deal with the interruption, and then, and this is the vital bit, start the prescribing process again from the very beginning.
Not from where you left off.
Never. You recheck the patient, the dose, everything. It's the slow is smooth, smooth is fast principle. Rushing that step and trying to multitask is a guaranteed route to a serious error and very low marks.
That's so tempting to ignore when you're busy, though.
It is. But the exam is testing your professional integrity. The data on error rates during multitasking is terrifying. You have to choose safety.
Okay, E is for.
Escalate early. Again, if you find your single tasking is constantly being interrupted, you escalate the system failure. You tell the site team you don't have enough staff to prescribe safely.
N.
Record decisions and plan. Document that you paused prescribing to answer the no WS2 call. Document the huddle, the delegation. It's your professional accountability.
Okay, our third framework is for when you're just being bombarded. Bleeps, calls from relatives, results, all at once.
Right. This is about managing the sheer volume of inputs. We call this the QUME strategy. The core idea is simple. Direct every single input to a single live queue.
To avoid hidden work.
Exactly. Your brain can't safely hold 5 competing priorities. Things get forgotten, usually the most important thing. A single visible queue on a whiteboard maybe eliminates that risk.
And to manage that queue, we use the ODT triage, so ODT.
The ODT triage makes the list actionable. Every item needs an owner. Is it me? Is it the F2? Is it the pharmacist? Someone has to own it.
Makes sense.
Second, it needs a deadline. For sepsis, it's 60 minutes. For routine TTOs, it might be midday tomorrow. Deadlines force action.
Anti.
The escalation threshold. This is the safety net. What happens if the deadline is missed or the patient gets sicker? The owner needs to know exactly who to call, the registrar, the site manager. Nothing is left to chance.
This framework also brings in the idea of batching. So when is it okay to batch tasks? And when is it a bad idea?
Batching is great for efficiency. It's when you group similar, low-value admin tasks together into a short, focused sprint, a time box.
It's like doing all the discharge letters at once.
Exactly. Or chasing 5 non-urgent blood results. You dedicate 20 minutes and just power through them.
But there has to be a huge clinical caveat here.
A massive one. And we have to stress this. Batching never, ever takes priority over an unstable patient. You batch the TTOs, but you triage the sepsis review or the chest pain. If a high WS score comes in during your batching sprint, the sprint stops immediately.
And you go back to the PRUDE or PASAR framework.
You go right back to high acuity triage. Prioritizing batching over a sick patient is a major SJT flaw. It's choosing convenience over safety.
Okay, we've covered managing time and tasks. Let's widen the lens now to resources and capacity, things like staff, diagnostics, beds. This is where that GMC mandate on sustainable resource use really comes into play.
Absolutely. Diagnostic capacity, especially things like CT and MRI scans, is a finite and expensive resource. The SJT loves to test your ability to choose the right test, not just the most advanced one.
So for this, we have the value framework. Let's start with V. Why is this so often a skip step?
V is for verify prior results. It sounds so obvious, but you have to avoid duplication. Before ordering a new test, check what's already been done.
People just reorder things under pressure.
They do, but repeating labs or imaging without a clear clinical reason wastes time, money, and exposes the patient to unnecessary risk, like radiation. It also delays the next patient who actually needs that CT scanner.
Okay, A feels very important for modern medicine.
A is for ask management impact. This is the crucial question. Will this test result actually change my management plan today?
So no fishing expeditions.
No. If the patient is palliative, or if the plan is already set, say they're going to theater regardless, then ordering more tests just for completeness is low value. Showing that restraint is a sign of maturity that the SJT rewards.
Then we have L.
L is for least burden equivalent. If you have 2 clinically appropriate options for a stable patient, you choose the one that's lower risk, less invasive, cheaper, or faster.
Give me an example.
Suspected gallstones in a stable patient. You book an abdominal ultrasound first, not a CT scan. The ultrasound is the least burden equivalent. It answers the question and saves the CT slot for the major trauma patient who really needs it. Documenting that tiered approach scores highly.
Right. And U is all about flow.
U is for Unite Flow teams. This means coordinating discharge planning early with pharmacy, therapists, and the site team to prevent that awful bed block we talked about.
And it's about being proactive.
Completely proactive. You need to be telling pharmacy at 10 a.m. that you have 3 TTOs coming, not dropping them on their desk at 4 p.m. when it's too late.
This brings us back to that classic TTO trap answer in the SJT.
Yes. The option to start the TTOs at 5 p.m. when the ward is quiet is a trap. It's too late to actually help patient flow. The high-yield, high-scoring action is starting them before midday and coordinating with everyone early. Preventing bed block is a system-level safety action.
And finally, E.
E is for escalate constraints and document rationale. If the CT scanner is down for 12 hours, or pharmacy is always understaffed in the evening, you have to document it and escalate it to management. You're making a hidden system risk visible. It's part of your duty to raise concerns.
Okay, now for a classic conflict scenario.
Yeah.
You're meant to be at a teaching session, but the ward is getting busier and busier. How do you balance that?
For this, we use the BOLAN framework. This is your safety checklist to decide if it's okay to step away for any non-clinical work. If you skip any of these steps, you're heading into low-scoring, unsafe abandonment territory.
All right, let's break it down. What's the non-negotiable first step? B.
B is for bedside first. You do an immediate scan of the ward's acuity. If there are a couple of high NUWS scores bubbling away or the nurse in charge looks stressed, you cannot safely leave. Clinical care always trumps teaching or meetings.
Simple enough. Next up, A.
A is for arrange competent cover. And the word competent is doing a lot of work there. It has to be someone of an appropriate grade and skill, like a colleague at your level or higher.
And they need to be briefed.
Briefed properly with SBR. And the absolute ironclad rule here is you can never, ever ask a medical student to hold the bleep. That is unsafe delegation and a guaranteed fail on the exam. Students are there to learn. They are not staff cover.
Got it. L is about transparency.
L is for sure. Let stakeholders know. Tell the nurse in charge you're going. Tell the education leader session might be delayed. Tell switchboard if you're on call. No silent exits. It prevents chaos if a patient suddenly deteriorates.
And the second A.
A is for agree thresholds and regroup times. You have to be explicit with your cover. I'll be back in an hour. If any patient's NUWS score hits 5 or more, call me immediately. If a K+ comes back above 6, call the med reg first. You also agree on a time to check back in. It protects the patient from the moment you leave.
And finally, N. Documentation again.
N is for note the plan, document the cover details, who's covering, what the thresholds are, make it auditable. So the ultimate rule is you can only leave if it's safe, with competent cover and explicit escalation thresholds. And if you're constantly having to cancel your protected time, you need to log it and raise it as a systemic issue with your supervisor. That's QI, not complaining. Okay, so let's really focus in now on the psychology of the exam. The SJT loves to use these really tempting decoy options to see if you'll choose convenience or fear over safety.
Right, let's break them down, starting with the most common one, tempting trap 1, ignoring acuity.
This is the one that says, do tasks in the order they arrived, or finish the discharge letter first to help with flow.
Or do the consultant's audit request because they asked for it urgently.
Exactly. All of these prioritize admin, bureaucracy, or hierarchy over objective clinical risk. They violate that fundamental sickest-first principle. The highest scoring action always addresses the immediate physiological threat first. No exceptions.
Okay, trap number 2. This one preys on the desire to be efficient. Skipping documentation or communication.
Yeah, you'll see options like skip writing detailed notes to save time, or just cancel the teaching session without telling anyone. This scores poorly because it breaks continuity of care, it risks errors, and it's completely unauditable. The time you think you're saving just creates massive risk down the line. Documentation is safety.
The third trap is a big one for junior doctor culture, I think. Avoiding escalation.
It is. These are the options that encourage you to struggle in silence. Keep trying to manage the 3 sick patients alone, or delay calling the registrar to avoid bothering them.
That's a real fear.
It's a huge fear, but in the exam world and in the real world, it's incredibly dangerous. It risks preventable harm because you're working beyond your safe limits. The SJT rewards the doctor who triggers the safety system early.
Oh, I want to push back on that for a second, though, because in reality, sometimes registrars are, shall we say, resistant to being called. How does the GMC framework protect you then?
That is a vital question, and the GMC absolutely protects you. Your professional duty is to raise concerns and work within your limits. If you've used an objective tool like a new WS2 and decided the situation is unsafe, you must escalate. If the registrar refuses to help, your high-scoring next step is to escalate past them to the consultant or the site manager.
You go up the chain.
You go up the chain and you document it. You write down, escalated to Dr. Smith at 18:30, response was X, escalated to consultant on call at 18.35. You are advocating for patient safety even against resistance. That is your duty.
That's a really clear and empowering way to look at it. Okay, trap 4.
Unsafe delegation. We've touched on this, but any option that says ask the medical student to hold the bleep or delegate a complex drug calculation to a new F1 without supervision is going to score terribly. It's a direct breach of GMC standards.
And the final trap is about losing control.
Abandonment or distraction. This is go to the meeting and turn your phone off. Or the human factors one. Multitask prescribing while talking to a relative on the phone.
Oh, that's a horrible one.
It is. It's abandoning your duty of care and massively increasing your error rate. You have to protect those high-risk steps by single tasking. The golden rule throughout all of this is triage by acuity, escalate early, delegate safely with SBAR, and document everything.
All right, let's do some rapid-fire drills to really embed these patterns.
Yeah.
Expert, you give me the safest, high-scoring move.
Do it.
If you're in the middle of prescribing insulin, a high-risk step, and you get a bleep for a new onset AF with a new WS score of 6.
Do. Protect the prescribing step. So you stop writing, make the drug chart safe, and log the bleep on your single queue. Then you immediately attend or assign the non-WS6 review. The patient review takes priority over finishing the prescription, but you must protect the prescribing process from error by restarting it later.
Perfect. If the CT scanner is fully booked for 2 days, but a chest x-ray would answer the immediate clinical question for a stable patient.
Do. Order the least burden equivalent. That's the value framework. Book the x-ray, document your rationale, and explain that you're using resources effectively to avoid delay.
Excellent. If you are repeatedly pulled from your protected teaching time week after week because the ward is just constantly unsafe.
Do. You need to log the pattern of impact, the lost training, the fatigue. Then you raise it as a structural problem with your supervisor and suggest a quality improvement project to fix the systemic understaffing. You're escalating a system failure.
Love it. If 3 calls come in at once, a critical K plus of 6.4, a nurse asking you to sign a routine TTO, and a consultant wanting a quick chat about a referral.
Do. Call a 60-second huddle, even if it's just in your own head. Triage immediately. The physiological threat, the K plus 6.4 is number 1. You deal with that. The consultant call is number 2, as that's a senior directive. The TTO is last. Acuity first, convenience last. That's pure PRUDE in action.
Last one. If
Yeah.
you're taking over a shift and the outgoing doctor says, oh, I've asked the medical student to finish off those 3 TTOs for you.
Do. Immediately and politely correct the unsafe delegation. You thank the student for their help, clarify their supernumerary role, and then you take ownership of those TTOs yourself, or you redelegate them safely to another doctor once all the sick patients are sorted. You have to fix the safety breach, even if it gives you more work. Okay, so to pull all of this together, let's just finish with the 3 core takeaways that will see you right in the SJT and on the wards.
Let's hear them.
Key takeaway 1. Acuity, which you measure with things like new WS2 and ABCDE, beats arrival order or convenience every single time. Sickest patient first. That is your non-negotiable mandate.
Got it.
Key takeaway 2. You have to actively create safety. You do that by pausing to plan that 30-second huddle-by, single-tasking, high-risk steps like prescribing, and by delegating safely using SBR with competent cover. And key takeaway 3, escalate your risks, both clinical risks and capacity risks. Escalate them early and escalate them robustly. And document everything. Your decisions, your cover plans, your communication. If it's not documented, it's not safe.
That's a powerful summary.
And here's the final thought I want to leave you with. The SJT isn't actually testing how fast you can work. It's testing whether you can slow down enough to plan safely.
That's a great line.
If you rush, if you multitask a critical step, if you fail to see when you've reached your capacity limit, you are no longer the safe doctor the GMC needs you to be. You become the risk.
Right.
Mastery of this is about structure, not speed.
A brilliant way to put it.
To keep mastering these patterns and get into the real nitty-gritty of the scoring, make sure you check out PassThemSRA.com. They've got some amazing high-yield strategies. And please retain the PASAR and PRUDE models. They will keep your patients safe and your score high.
Okay, let's put that structured knowledge to work. Until the next deep dive, keep learning.